This is Lecture 1, Anatomy and Physiology of the Urinary System. The kidneys are retroperitoneal organs lying near the posterior body wall, just below the diaphragm. Left kidney is inferior to the spleen, and the right kidney is inferior to the liver. The right kidney is slightly lower than the left kidney because the large right lobe of the liver pushes it downward. Both kidneys do move when the patient breathes in and out. They'll move downward approximately a full inch. They're going to be dark red bean-shaped organs measuring 9 to 12 centimeters long, 5 centimeters wide, and approximately 2.5 centimeters thick. The outer cortex is darker than the inner medulla because of the increased blood perfusion. The inner surface of the medulla is folded into projections called pyramids. The pyramids empty into the renal pelvis, and the arcuate arteries are also located at the base of the pyramids. These pyramids are going to separate the medulla from the cortex, and all the little collecting tubules are going to be found in the pyramids or close to the pyramids. The tubules bring the urine from the sites of its formation in the cortex to the pyramids. The tubules or nephrons are the functional units of the kidney. If you watched Hank's videos, he went into great detail on the nephrons. The hilum is the indentation on the medial surface of each kidney, the vertical indentation. It's where the renal vessels are going to enter the kidney and where the ureter is going to exit it. Other vascular structures, the ureter and the lymphatics are also going to be found within the hilum. On the right, the renal artery sits posterior and superior to the renal vein. There are going to be two renal vein branches anterior to that renal artery. In transverse, this is what it's going to look like on ultrasound. And I'm going to get my little laser pointer out here. So we have liver up here, right? Transverse kidney here. And then this is one of my favorite pictures actually because they highlight everything over here so you can see what each of these structures are. You've got that renal pelvis or that hilum right here where the renal vein is going to enter the kidney or exit the kidney. The renal artery is going to enter the kidney and the ureter is going to exit the kidney along with other lymphatic vessels. You've got a darker ring out to the edge of the kidney that is the medullary fat, and then you've got the lighter sort of purplish pink, which is the cortex of the kidney. Your pyramids are these yellow things here. Over here, they're these anechoic to hypoechoic circular structures. You want to be careful you don't mistake those for cysts. Now, the renal fascia is also known as Geroda fascia, and it's a layer of connective tissue that encapsulate the kidneys. Just as the liver has a capsule called Glissen's capsule, the kidneys are also encapsulated by Geroda's fascia. There's a layer of perinephric fat which covers that renal capsule and is below the renal fascia. And then the cortex lies beneath the renal capsule. So the cortex is that outer ring of hypoechoic tissue that we see around the kidney. And anterior to the right kidney, you're going to have the right adrenal gland and the liver, Morrison's pouch, the second part of the duodenum, and the right colic flexure. Anterior to the left kidney is going to sit the left adrenal gland, the spleen, the stomach, and the pancreas, the left colic flexure, and the coils of jejunum. That's what was in front of it. Behind each of the kidneys, we're going to find structures as well. Behind each of the kidneys, you're going to see the diaphragm and the costodiaphragmatic recess of the pleura. Behind the right kidney will be the 12th rib. Behind the left kidney will be the 11th and 12th ribs because remember it sits a little higher. The psoas muscles, the quadratus lumborums, and the transverse abdominis muscles are also posterior to the kidneys. The renal pelvis is the upper expanded end of the ureter, and it sits in the hilum of the kidney. It's divided into 2 or 3 major calyces, and each major calyx is going to further divide into 2 or 3 minor calyces. The renal papilla, the apex of a medullary pyramid, indents each of the minor calyx. So everywhere you have a minor calyx, you're going to have a medullary pyramid. This is going to be called the renal papilla. Now the renal pyramids, these make up the medullary substance, okay? They can be anywhere from 8 to 18 in number. The bases of the pyramid are towards the outer circumference of the kidney. The apex is going to indent those calyces. And the apices are going to converge towards the renal sinus. Prominent papilla project into the lumina of the minor calyces. So these are going to look sort of like a corn kernel or the crown of a tooth. Now the nephrons, we said, were the smallest functional unit of the kidney, and there are 2 main structures in there, the renal corpuscle and the renal tubule. And their function is to filter the blood and to produce urine. So the blood filters into the renal corpuscle, and the filtered fluid is going to pass through the renal tubule. As it moves through the tubule, substances that are needed by the body are returned to the blood. So remember, as Hank said, everything comes out, like cleaning out your fridge, and then we put back the things that we want to keep. The waste products, the excess water and other substances that are not needed by the body, are going to pass into the collecting ducts as urine. The renal corpuscle itself is made up of a network of capillaries called the glomerulus, surrounded by a cup-like structure called Bowman's capsule. And then you've got different arterioles in there. The afferent arterioles flow into the glomerulus, and the efferent arterioles flow away from the glomerulus. The efferent arterioles conduct blood to a second set of capillaries that surround the renal tubule, and filtrate passes into the renal tubule through an opening in the bottom of Bowman's capsule. The first part of the tubule is coiled and is called the proximal convoluted tubule. After passing through that part, the filtrate flows into the loop of Henle and then into the distal convoluted tubule. So it's going to go through the proximal convoluted tubule, down through the loop of Henle, and then into the distal convoluted tubule. From those distal convoluted tubules, the urine is going to drain into a collecting duct. Several nephrons will feed into a single collecting duct, and portions of that distal convoluted tubule will curve upward and come into contact with the afferent and efferent arterioles. Some of the cells of the distal convoluted tubule and the afferent arterioles are modified to form the juxtaglomerular apparatus, which is a structure that helps regulate blood pressure in the kidney. From the collecting ducts, urine is going to flow into the minor calyces and then into the major calyces and the renal pelvis and eventually into the ureter. The ureter is a 25 centimeter long tubular structure. The proximal end is that pelvis, and it's expanded and continuous with the renal pelvis. The pelvis lies within the hilum of the kidney and receives the major calyces. Once it emerges from the hilum of the kidney, it's going to run vertically downward behind the parietal peritoneum and follow along that psoas muscle. It's going to enter the pelvis by crossing the bifurcation of the common iliac artery anterior to the SI joint, the sacroiliac joint. From there, it's going to course along the lateral wall of the pelvis to the region of the ischial spine, and then it's going to turn forward, and it's going to enter at the lateral angle of the bladder. It's located in the retroperitoneal cavity, so oftentimes we cannot see it unless it's dilated. If the ureter is normal, it's very often obscured by bowel gas, and we cannot follow it all the way from the kidney to the bladder. If there are constrictions along the ureter's course, the places that it's likely to get kinked or constricted is going to be as it leaves the renal pelvis. It can get kinked where it crosses that pelvic brim, And then the final sort of weak spot in the ureter is going to be where it pierces the bladder wall. That's another place where we can see strictures. Once the ureters pass into the bladder is going to hold the urine until we expel it through the urethra. So this is going to be a large muscular bag, and it has posterior and lateral openings for those ureters. The urethra is going to sit anterior, so the opening for the urethra is more anterior than where the ureters dump in. The interior is lined with very highly elastic transitional epithelium. That's what allows it to expand and contract. And the urine is produced almost continuously, so it doesn't just dribble in, it actually jets in. So it comes down, the ureters can peristalse, and then they push the urine into the bladder. The urine accumulates in the bladder until the increased pressure is going to stimulate the nervous receptors to relax the urethral sphincter, and then the urine will be released from the urinary bladder. We can definitely see this sonographically, the bladder itself. In fact, we use it for a window often with pelvic ultrasound. We can also see those urine jets firing into the bladder. We use those as sort of an indirect evidence of good kidney function. And then lastly, we have to talk about the urethra. This is a membranous tube that passes from the anterior part of the urinary bladder to the outside of the body. There are two sphincters in there. There's an internal sphincter and an external sphincter. Routinely, we don't see this on sonography either. However, we can often see the little indentation in the anterior inferior part of the bladder where the urethra connects to the bladder. All right, vascular supply. The vascular supply to the kidney is going to be through that main renal artery. It's going to divide into two primary branches, and a larger anterior artery and a smaller posterior artery, and then those arteries are going to break down even further. You do want to know the arteries of the kidney. So it's going to go from main renal artery to segmental arteries. The segmentals are going to branch into interlobar arteries, and the interlobar arteries are going to branch into arcuate arteries. The arcuate arteries break down even further into interlobular arteries. We don't typically mess with the interlobular arteries, but we do Doppler the segmentals, the interlobars, and the arcuates. Now, on the way out, blood draining from the kidney, you're going to have 5 to 6 veins that join to form the main renal vein. The main renal vein is going to emerge from the hilum and anterior to the renal artery, and the renal vein is going to drain into the lateral walls of the IVC. We talked about those teeny tiny nephrons. Blood supply for the nephrons begins at the renal artery and then goes through the branches, the segmentals, the interlobars, and into the arcuates. The small vessels from there, the arterioles, we're going to see a small vessel, an afferent arteriole, moving towards the capsule. It enters Bowman capsule, and it forms a little tuft of capillaries. That's the glomerulus. Looks like a ball of yarn. This is going to fill the concavity of the capsule, so it sits inside Bowman's capsule like a ball of yarn in a cup. Blood leaves the glomerulus through the efferent arterioles, and then that's going to subdivide into a network of capillaries that surround the proximal and distal tubules, and then eventually they're going to unite as veins, and they're going to come together to form subsequently larger veins, which finally become the renal vein. That takes care of anatomy. Let's move on to physiology and lab data. Okay, 2 kidneys, 2 ureters, 1 bladder. The kidneys are going to remove waste from the blood and produce the urine. The ureters are going to act as tubal ducts that lead from the kidneys and drain into the urinary bladder. And the bladder is going to serve as a collection and storage unit for the urine, which eventually will be discharged through the urethra. So the kidneys play a number of roles in homeostasis. One of the things they do is adjust the amount of water and electrolytes leaving the body so that they equal the amounts of substances entering the body. This is why we produce more urine when we're well hydrated and less urine when we're dehydrated. And the formation of urine is going to involve three processes: that glomerular filtration that we talked about, the tubular reabsorption, and the tubular secretion. So excretion itself is a process of separating and removing substances that are harmful to the body. The metabolic activities at the cellular level are going to produce waste products. If we do not excrete them from the body, they can reach toxic levels. We see this in people whose kidneys have failed. It's why we do dialysis. Otherwise, it doesn't take long and then too many toxins build up in the bloodstream and it can lead to death. Now, the kidneys are not the only organs to have excretion functions. The skin, the lungs, the liver, and the large intestine also participate in excretion. The main metabolic waste products are going to be water, carbon dioxide, nitrogenous wastes, which include things like urea, uric acid, and creatinine. There are a number of lab tests that can be performed to assess the function of the kidneys. We do this because the symptoms of kidney problems is kind of non-specific. So oftentimes we'll need to see what the lab data shows as well. So urinalysis is how we test for a lot of these things. We're going to see what the urine pH is, whether it's acidic or alkaline. The specific gravity, which is a measure of the concentration of the urine, and we see a low specific gravity in the presence of renal failure. We check for hematuria, blood in the urine. We can also do blood draws and check for hematocrit. That's the ratio of plasma to blood products. Hemoglobin. Hemoglobin is important to know because if there's too much hemoglobin going through the kidneys, it can actually damage the kidneys when they're trying to filter things. It damages the nephrons. And then protein. We can test for protein concentration in the urine, and creatinine clearance, how much creatinine the kidneys are actually clearing from the blood. We can do, again, blood draws for blood urea nitrogen. In the case of renal failure, the BUN is going to be elevated because the kidneys are not filtering it out at the rate that they should. And the same is true for serum creatinine. If we have a low urine creatinine clearance, we're probably going to have an elevated serum creatinine. That takes care of physiology and lab tests. Let's talk about how to ultrasound the kidneys. So patient prep, there really isn't much. They don't need to be NPO. We do like them to come with a relatively full bladder so that we can see the urine jets. Positioning, we're going to put them in supine for the most part. However, we may find that rolling them right or left lateral decube gives us a better opportunity to see the kidneys. And if it's a pediatric patient or an infant, we will often image the kidneys from the back, so we may even have the patient prone. We're going to take sagittal pictures, transverse pictures. We're going to measure those kidneys, put color Doppler on them, and then we'll be done. We need sagittal views, and I like to start lateral and just work my way medial, get everything I need from the mid-kidney while I'm there, and then keep going. So you need an image of the sagittal right kidney lateral, the sagittal right kidney mid. This is where you're going to measure the length of the kidney. This is also where you're going to put color Doppler on the kidney. And then you need a right kidney sagittal medial. So 1, 2, 3, 4, 5 pictures in sagittal. Now remember that the kidneys don't sit in there perfectly straight up and down in the same sagittal plane as the body. They're typically slightly oblique, anterior to posterior, and lateral to medial as well. The inferior pole tends to sit a little more medial and a little more anterior. So when we go transverse, we want to be 90 degrees from wherever we found the best sagittal image. And we're going to get a right kidney superior, We're going to get a mid-right kidney that includes that renal hilum and that renal vein. It should serve as your landmark. You want a grayscale of that, and then you're going to measure the AP and the width. And then you're going to put color Doppler here as well. And then you're going to get a right kidney inferior. So here's our sagittal and our transverse kidney. You want to see both those poles at the same time to know that you're truly lined up with the long axis of the kidney. So we're going to measure here. Let's see. There we go. So to measure the long axis of the kidney, you go superior to inferior pole. I'm drawing from inferior to superior just because it's easier on my computer, but it should look something like this, nice and straight. Okay, our calipers give us nice straight lines. Notice we have renal cortex showing all the way around here, and then renal sinus, the sinus is echogenic, and we can see that in the center of the kidney. When we go transverse, it's 90 degrees of our sagittal. Same thing, we're going to get a width and an AP. Your width, no matter which way your kidney is oriented, your width is going to be from the renal hilum to the lateral part of the kidney. And you don't want to go all the way out here. You want to come in, think of this as sort of like a head of broccoli. You're going to measure kind of like that. Then you're going to come across like this, 90 degrees from your first measurement. And you're going to get your AP and your width. Once you've imaged the right kidney, you're going to move across the body to the midline. You're going to get a sagittal IVC with colored Doppler to prove patency. And you're going to get a sagittal aorta with a measurement, just a representative image. I like to do this one at the level of the renal artery origin. Then we're going to move to the left and image the left kidney. We're going to repeat those sagittal images, lateral to medial. So a lateral, a mid in grayscale, a mid with length inferior to superior pole, and then a color Doppler. And then we're going to get a medial sagittal image. Then we're going to turn 90 degrees and repeat those transverse images. A superior, a mid with the renal vein and the hilum, AP and width measurements, color Doppler, and then an inferior. Once we have both kidneys, the aorta and the IVC, we're going to move inferior to the bladder. You want your patient back supine for this if you rolled them for the kidneys. And you're going to get a sagittal image of the mid-bladder. You're going to get a length and a height there. And you want a couple images to the right, 1 to 2, and then you're going to take a couple sagittal images to the left, 1 to 2. You want to then turn transverse. You want a superior bladder, a mid-bladder. At the mid-bladder, you're going to go ahead and measure the width of the bladder, and you're also going to measure the wall at the anterior part of the wall. And you want that sound beam perpendicular to the part that you're measuring, just like you would on the gallbladder. Then you're going to get an inferior bladder. Then you're going to put your color Doppler on, and you're just going to sit there and wait. You're going to watch for right and left urine jets and try to catch them with color Doppler. I recommend that you turn the Doppler gain up just until you start to see some confetti, and then back it off just 1 click. That's going to give you the best opportunity to see those jets go off. You're going to want to stay sort of inferior, and you want to remember that they're going to enter the bladder at the posterior wall, so watch for them along the posterior wall. If you're imaging a man, you're also going to want, and you can see it, you're also going to want to image and measure the prostate in sagittal and transverse. So here we go, we're looking at the bladder. Now, one thing I will say about the bladder, it's always lower than you think it's going to be. One of the landmarks that you want to use is that pubic symphysis. You want to be just immediately superior to the pubic symphysis. Okay, in females, we will see the uterus superior and posterior to the urinary bladder. You want a sagittal image and a transverse image. And here we have one of the urine jets. I'm going to go out on a limb and say this is the left jet because it's shooting from the left side of the bladder to the right, typically your left jet will look this way, your right jet will come in this way, okay? And you'll notice that they are along that posterior wall. And then finally, I did mention that in men, if you can see the prostate, you want to go ahead and image that in sagittal and in transverse as well. I'm going to put on my laser pointer here and point out that prostate for you. So this is a transverse bladder here, and right down here, this hypoechoic area is the prostate. So same thing, you're going to get a transverse image without measurement and with calipers with measurement. You're going to do a width here. You can then in sagittal, same thing, one grayscale and one with a measurement length and height, so height and AP. And once you've done that, you'll have all the images you need for the renal complete ultrasound. This concludes lecture 1. Lecture 2 will be on pathology.